let's get started. Welcome to HIV Grand Rounds. I am so excited to introduce our two speakers for this, what will be a phenomenal session. We have Dr. Nicky Mehtani and Dr. Stephen Matzat here to talk about low barrier HIV care in street medicine. And they have both data about their program as well as a case-based talk. And so just really excited to have them both. Dr. Stephen Matzat will start us off. He's a physician specialist with the San Francisco Department of Public Health, is a family medicine physician who is an addiction medicine specialist trained in our program here. And provides care both in the WIPIC street medicine family and as part of jail health. Dr. Nicky Mehtani is an assistant professor of medicine in DGIM here at UCSF, where she also completed the addiction medicine fellowship here, spent time at Ward 86. And in addition to her investigator work, which involves some really fascinating trials related to psychedelic medicine, and stimulant use disorder treatment, which we can pick her brain about another time. She also does clinical care at MXM, where she's led the implementation of their long-acting ART program. So let's welcome them both, and we'll take questions at the end, so feel free to put questions in the Q&A, and we'll get to them there. And without further ado, welcome to our speakers.
Thank you, Aisha, and thank you everyone for coming in today. Just to give a roadmap of where we'll be going today, I'll be giving us an introduction into the epidemic initiatives that we have been doing at Whole Person Integrated Care in the DPH, followed by some introductory epidemiological data about our panel of patients who are living with HIV at Whole Person Integrated Care. Nicky will then take us through some clinical cases, and that will be largely the bulk of the discussion, followed by some brief outcomes data, and then hopefully we'll have time for a robust discussion thereafter. So at Whole Person Integrated Care, let me just give you a general sense of the breadth of our services here in San Francisco. Our bedrock of care is really going to be at, can you see this? Yes, Maria X. Martinez Clinic. It's a drop-in clinic for people largely who are experiencing homelessness or housing instability. It really is there for those who cannot make it into care elsewhere. No appointments are necessary, Monday through Saturday, 8:30 to 4. We work closely with shelter health teams where we have nurses embedded within the shelters along with providers as well. And they are to serve people who are living in the shelters. Additionally, we have street medicine outreach teams who work closely with our enhanced care management network through street medicine. Also within the umbrella of Whole Person Integrated Care is a sobering center, medical respite, gaining increasing importance with people becoming housed. Is the Permanent Housing Advanced Clinical Services team, and those are providers and nurses and case managers who go into the permanent supportive housing to support those who are having difficulty even getting out of there and into the clinic system. Finally, we have within the permanent supportive housing, some of the units have embedded nurse clinics for people who need that on-site service every day. Now, our initiative for ending the epidemic is really focused on Maria X. Martinez Clinic, as well as our close partnership with both the shelter health and street medicine teams. So the data that we'll be going through is really for patients who are serving in these areas. So what does our ETE team do? It does a lot. For the last year or so, we've been doing some population management for our panel of HIV patients, and that's been about 133 people who we've served in what we're terming transitional primary care. Part of that includes those patients who are on long-acting injectable ART, as well as PrEP. We also have nurses and health workers who support our efforts for treating hepatitis C, responding to STIs, and doing point-of-care screening in the various locations that were embedded throughout the city. And just to highlight that the work that we're doing in serving people with HIV and all the STI work, it's really work that we've been doing for many years. And the epidemic component of that is a new team that is meant to support the work that we've already been doing to make it more robust and to increase the follow-up and the follow-through. So who makes it into our transitional primary care panel of people with HIV? The eligibility that we have come up with is you will be living with HIV. You come in and you see at least 2 providers on 2 occasions within the last 12 months. And one of those visits includes a prescription for ART. You need to be not established in HIV care elsewhere. And we additionally will bring in people to our panel who are, say, a new diagnosis on their first visit for obvious reasons. So the goals of our transitional primary care are to stabilize, to support med adherence, to suppress viral load, increase CD4 count, and ultimately, really the goal that we're always trying to think about is when and how and where are we going to link you to care for your permanent HIV care home. Similarly, when we're thinking about who we're starting on long-acting injectable, and you'll see some of this in action as Nicky goes through the cases, the sorts of discussions and considerations that we go through, but we like to have people who have been engaging with our team for at least 3 months. Given the high intensity of resources it takes to follow these people with long-acting injectable treatment, we are selecting those who have lower CD4 counts and who are not virally suppressed and who really have proven that they can't make it into care elsewhere. The goals are the same really as the general transitional primary care. So I'll go through some of the demographic data of those that we've served, and you'll see on this column here, these are all people living with HIV who we've served in transitional primary care for the last year since we started tracking this data. And then not perfectly matched, but the columns here are those who are on long-acting injectable ART since 2021. Because Nicky's been doing this work with LAI for much longer. Some key things to point out are that our population, interestingly, of those who are non-white is really two-thirds of our entire panel here. Yes, and even more so moving into the LAI ART, about 4 out of every 5 patients on long-acting injectable are of non-white race ethnicity. Those who are trans or non-binary, we have in our panel about 1 out of every 10, and those who are on LAI have been 2 out of 10. Finally, you'll see that the housing status of those who are serving is very much skewed towards unsheltered homelessness and unstable housing. And those who we do end up selecting based on those aforementioned factors for long-acting treatment are those who are largely unsheltered and or experiencing sheltered homelessness. The patients we serve have many comorbid mental health challenges, namely about 2/3 with a stimulant use disorder and 80% of those who were on LAART with a stimulant use disorder. Similarly, high rates of opioid use disorder and serious mental illness. Amongst our population of people who is on our transitional primary care panel, about 40% either have a diagnosis of bipolar disorder, schizophrenia, or psychosis, NOS, on their problem list. We do see a lot of patients who don't necessarily have AIDS or severe immunosuppression, but you'll see in the difference in the general transitional care population and those who are on LAART that we have done a good job at selecting those who need it most in terms of their risk for opportunistic infections and need for prompt viral suppression. So in the last year, we've served 133 people living with HIV in our transitional primary care. We're proud to say that 30% of those have been linked to a permanent HIV care home, including 5 of those who are on LA-ART. 13% have been lost to follow-up and 1.5% have since passed. And about a third of our population is on LA-ART that we're following. So that's the demographic data, thank you. And I will pass it along to Nicky Mehtani.
Thanks so much, Stephen. So these 2 cases that I'm about to present are kind of 2 illustrative cases that present some of the more complicated issues that we run into, particularly with long-acting ART in our population. At the end, I'll kind of come back to our data of the overall program. So for our first case, so this is a 30-year-old male with HIV, a low CD4 count of 18, and a viral load of 270,000, hepatitis C, severe opioid and methamphetamine use disorders, and PTSD. He's been street homeless in San Francisco for 8 years, but did not engage in any sort of medical care in the city until 2021. And he's repeatedly been unable to adhere to daily oral medications, which has been evidenced by 2 separate unsuccessful attempts to treat his hepatitis C. With regard to his opioid use disorder, he's been able to induct onto buprenorphine a couple of times while in jail. And from that, he was able to actually start long-acting buprenorphine at one point. This unfortunately did not stick. It lasted about 2 months before returning to daily fentanyl use. He was diagnosed with HIV in 2011 with a primary risk factor of engaging in sex with men. Prior to 2017, he'd been on regimens of boosted atazanavir with tenofovir FTC, as well as a single tablet regimen of efavirenz TDF FTC. Since 2017, he's largely been off of all ART due to inability to take his medications in the context of homelessness and severe mental health instability, though he has been prescribed at various times darunavir and bictegravir-based regimens. His CD4 count currently is 18, but it's actually been less than 30 for the last 2 years since he started engaging with our team. And he has active chronic bacillary angiomatosis, for which he's been unable to adhere to treatment, as well as a history of undifferentiated watery diarrhea for 2 years. His RNA genotype was notable for an M184V, as well as a V179D, which is a minor NNRTI mutation. So for our first audience response question, I've included some of the background info at the top of the slide. But the question is, what ART regimen would you recommend for this patient? Would it be A, once daily darunavir, CoB, TAF, FTC with directly observed therapy support through the treatment access program? B, CAB-RPV once monthly. C, CAB-RPV every 8 weeks. D, CAB-RPV monthly plus lenacapavir every 6 months. Or E, would you hold ART until he's better able to engage in care? Okay, we'll give folks maybe like 10 more seconds to answer here. And then, okay. So it seems like most people said B. Let's try CAB-RPV monthly. And that is what we ended up recommending and starting for him. This was back in 2022. So option D, which was combination of Cabenuva plus lenacapavir, was not an option quite yet. So what did this look like? He initiated the loading dose of CAB-RPV despite the baseline V179D, which we didn't think much of at the time, still don't think much of. And initially he did quite well. He returned a month later, got his injection. His viral load was downtrending quite a bit. It came down to 46 after 1 month. CD4 already started uptrending. And this continued for a little bit. His 3rd injection was also on time. His viral load is now suppressed. CD4 came up to 87, and his diarrhea is actually improving quite a bit, and he's gaining weight at this point, just after 2 injections. Sorry. So after that, he does come in for a fourth on-time injection. But at this point, he is starting to, he has a history of PTSD and has some intrusive thoughts that have been starting to come up. And at this point, he declines labs, says he is really depressed, and he's subsequently really difficult to find in the community. When we do find him, he declines to come back in for his injection. So while we were actually able to locate him a few times, he didn't want to come back in. 3 months later, he does come back in. We think in part because he starts to have recurrent diarrhea, and he really wants to restart long-acting ART. He doesn't have a clear, in terms of why he disengaged from care. It's largely due to mental health issues, and he feels bad about it. He wants to come back, and understands that this might not be an option. We did get labs and did try to restart CAB-RPV, but his labs did come back with a elevated viral load of 167,000, and his genotype now has new kind of extensive RPV resistance, a new Y181C and M230L. So he now has high level RPV resistance. Second audience response question is, what ART regimen would you now recommend? And the data is all at the top here. Again, he wants us to restart long-acting ART, but now has extensive RPV resistance. Right. So in terms of responses, sounds like most people are saying B, let's restart the cabotegravir once monthly in combination with lenacapavir every 6 months. And that's actually ultimately what we did. It's a little bit of a trick question at the time. Lenacapavir still was not around, so we could not do that. So we did discontinue his CAB-RPV at this point, and we tried to start darunavir-based daily oral therapy through the treatment access program. It did not work very well. So a couple months later, once lenacapavir was FDA approved, we did go with option B. And how did this ultimately turn out? So he started the loading dose of just cabotegravir now in combination with lenacapavir, including the oral loading dose, again with this RPV resistance, and this worked pretty well. So he had his next several injections for the next 6 months at least. He was completely on time. He resuppressed his HIV viral load. His CD4 came up tremendously. Remember, this was a patient who had a CD4 count of less than 30 for over 2 years. After his 12th dose, however, he had one injection where he was just 12 days late. And again, this is an unstudied regimen of cabotegravir, or at the time, an unstudied regimen of cabotegravir plus len. And he had this one-time viral load of 208 copies. The genotype could not be processed because it was too little virus. So we decided to continue the regimen to see what happens. Fortunately, his next dose, again, it was on time, but his viral load came up to over 2,000 copies. So this was pretty concerning. And surprisingly, his genotype again could not be processed. And this time it was really unclear what went wrong, because usually, as you're all aware, the viral load usually can be processed at anything above 500 copies. In general, we've seen it with anything above 30 copies. We actually sent this out because he's on lenacapavir now. We did send out testing for resistance testing to lenacapavir as well. And they were unable to process that genotype. For that, they say that they need 1,000 copies. So honestly, why we weren't able to get the genotype, I don't have a great answer for. I think it's something that we can come back to in the discussion if people want to discuss this more. But then the question is, like, what do you do at this point? Because I'm pretty worried at this point, if he has a viral load of over 2,000, that he's developed resistance either to cabotegravir or lenacapavir. Should we continue this or not? Because the alternative option, he's not able to take oral meds. He's really demonstrated that for years. And then again, even after starting the long acting, we decided to kind of push forward and see without any evidence clearly that this was not working. Let's go ahead and continue this. And somewhat surprisingly, his viral load resuppressed. and it's been suppressed for over a year since then. And his CD4 count has continued to uptrend. So he's still on this regimen, and he's doing, I guess, at least from an HIV perspective, relatively well. There's a few things that we could discuss about why this happened, how this happened, but we can return to that after our next case. So for this next case, one sec. Okay, this next case is a 43-year-old gentleman. Sorry, I'm trying to find. 43-year-old gentleman with HIV. His CD4 count is a little bit higher this time, 187, viral load of 178,000, has hypertension, major depression, and severe methamphetamine use disorder. On his very first visit to MXM, which was a couple of years ago, he came in specifically requesting to start long-acting ART. He'd been having considerable challenges adhering to daily oral medications and says that he really hates swallowing pills. He's also sexually active with men, including working as an escort. And with regard to contact information, he does not have a cell phone, but he does plan to remain living in San Francisco indefinitely, and he feels strongly that he can remember to return to our clinic for injections on his own accord. He's also able to provide his mother's phone number as an emergency contact. He'd moved to San Francisco 3 years prior, hadn't engaged in any care since then. He's mostly staying in shelters, but recently was placed in a transitional housing unit by the homeless outreach team. He was diagnosed with HIV initially in 2005. After his diagnosis, he didn't start ART for 5 years until 2010, when he was hospitalized for a diagnosis of cryptococcal meningitis, after which he'd become pretty adherent to boosted atazanavir plus TDF-FTC between 2010 to 2019. After that, he'd become homeless and again stopped taking all of his ART and other medications. His RNA genotype is notable for K103N and V108I, which portends potential low-level resistance to RPV with a Stanford score of 5. So our next audience response question is, what ART regimen would you start for this patient today? Would it be daily oral darunavir-CoV TAF-FTC, BIC TAF-FTC, CAB-RPV once monthly, CAB-RPV every other month, or E-CAB-RPV monthly plus lenacapavir every 6 months? All right. So most people are saying E, CAB-RPV monthly plus lenacapavir. Some people said C, CAB-RPV every 4 weeks. We actually, in this case, did not start, didn't start long-acting ART immediately. The reason for that was, remember, he'd been living in San Francisco for 3 years, but this was his very first visit to MXM. So we hadn't really built much of a rapport with him to really know for sure that he'd be able to return to clinic regularly. We also didn't have a great outreach plan of where to look for him if he didn't come back for injections. He was staying at this new supportive housing, but unclear how long he would be able to stay there. So we didn't feel great about starting him right away at this very first visit. So we said, okay, let's try to engage with you and have you come back. We're going to start BIC TAF-FTC, and we'd love to continue working with you. So at this first visit, we discussed the pathway for starting long-acting ART with him, prescribed BIC TAF-FTC daily, and he declined a referral to links at the time. 3 months later, he comes back to MXM. He says that he's never picked up the BIC TAF-FTC prescription, and he's largely remained off of, he has completely remained off of ART. He continues to work as an escort. He's still very interested in starting long-acting ART, and he's willing to come in weekly to initiate injections. He still has no cell phone, but now he's been in this transitional housing unit for 3 months, so he can demonstrate that he's potentially at least locatable in the community. So fourth audience response questions, very similar to our last question. No major changes here. It's just been 3 months later, has not been successful with initial plan to trial the oral daily BIC TAF-FTC. All right. So now most people are saying kind of same answers as before, C and E. I think that either C or E potentially could be correct here, and that's part of why I wanted to present this case. At this point, it was still very early on with lenacapavir, and so we didn't have a lot of experience combining the two. So we did just go with CAB-RPV once monthly. If it was happening today, our decision making might be a little bit different. So then what actually happened with this case? So initially, he presented for his first CAB-RPV initiation dose, which goes well. However, he notably, when he came back for this first dose, was significantly more agitated at the time of his first injection than he had been during the previous visits he'd had with us. His second dose was then administered on time. He actually presented early for the injection. However, after the second injection, he, for whatever reason, was exited from his transitional housing unit. And this loss of housing led to significant difficulties with locating him to remind him of his next injection. So 12 days after his third injection was due, he did present to jail. And so we were able to administer his third dose through our collaborations with Jail Health Services. And his viral load was noted to be less than 30 at the time, which was somewhat reassuring. After leaving jail, he became street homeless. And while we were able to figure out a way to outreach him through a family member to remind him to present to clinic, he was increasingly frustrated at this point, understandably, with the new street homelessness. And and he at that point declined to get labs drawn. He was there for his injection, but really felt like he couldn't do more than that. So then this next injection continued to be very difficult to locate in the community because he doesn't have a specific place that he's staying. He doesn't have a cell phone. His mother, who was our contact person for him, doesn't know where he is anymore. So we outreached him at several locations, weren't able to find him until he was 21 days late for his injection. We found him at a shelter. And so we reinitiated CAB-RPV. He again declined labs. Again, he's pretty agitated and interested in continuing this medicine, but really doesn't have it in him to present on time anymore. So then when we finally were able to get labs at his next injection, his viral load was 37,000 and his genotype was pending. We knew that his RNA genotype would take about 3 to 4 weeks to return. But with this new pretty substantial viremia, our next question is, what would you do for him while we're awaiting his genotype results? So his viral load is 37,000. He's had 2 delayed CAB-RPV doses, one by 12 days. After that, his viral load appeared to be suppressed in jail, but then he had a subsequent late injection that was 21 days late. So options are, would you discontinue CAB-RPV and start daily darunavir-CoV TAF-FDC? B, continue CAB-RPV monthly, start darunavir-CoV TAF-FDC as well. C, continue CAB-RPV and then also start the lenacapavir. Or D, would you not really know what to do at this point and want to kind of cry in the bathroom? So this is probably the most complicated question that we have so far. So I'll give you guys a few seconds to finish up. All right, so answers are kind of all over the board here. And I appreciate this because I felt kind of overwhelmed by this situation at this point. Not to mention that the patient was pretty aggravated with us telling him that his viral load had uptrended, and he was pretty adamant that he didn't believe in that viral load, and he was saying, I need to continue this medicine. I can't go back to oral meds. So we considered all of these options. Ultimately, because he said, I'm not going to take oral meds, and he'd already demonstrated that he could not take oral meds on a previous attempt, we did go with option C, which while awaiting while awaiting the genotype results, we opted to start lenacapavir. The thinking here was we expected that he developed resistance to either cabotegravir or rilpivirine. We were hoping that he didn't develop resistance to both. And at the time, there wasn't a lot of data to understand whether he would develop resistance to both or one or the other. So we thought if we start lenacapavir, he'll have one fully active agent, and hopefully he has another one as well. However, his resistance profile then came back a few weeks later, and he had very extensive new resistance to both cabotegravir as well as rilpivirine. So this, at this point, option D was kind of where we were at. It felt like it was largely a failure. What ended up actually happening, so yeah, what ended up actually happening is, so like I said, we did administer CAB-RPV plus lenacapavir loading dose at his last visit. This was prior to the genotype returning. And then upon review of the genotype findings that demonstrated both RPV and CAB resistance, we did kind of explain this to the patient and recommended that he start darunavir-CoV TAF-FTC, largely to avoid developing new resistance to lenacapavir now. Because he already has CAB-RPV resistance, he's at really high risk, we thought, for lenacapavir resistance, because he's essentially on lenacapavir monotherapy at this point. He insists on continuing this regimen anyways. We say, no, that's really not an option at this point. The science doesn't really support that, or the data doesn't suggest that we can do that. So we stop the CAB-RPV, do prescribe darunavir-CoV TAF-FTC. He doesn't pick it up, and he ultimately disengages from care. 38 weeks later, he returns to MXM because he has an abscess to get an incision and drainage procedure. And he reports, as expected, that he never picked up nor started the darunavir-CoV TAF-FTC. We confirmed that from the pharmacy records. He never picked this up. Yet his viral load is less than 30 copies. And so I can't necessarily explain why this happened. We thought maybe this is just an anomaly. We repeated it. It was still less than 30 copies. So this is 38 weeks later. It's almost a year. At this point, after kind of discussing it with some other folks, we don't really have a good reason as to why the viral load is less than 30 after just being on lenacapavir monotherapy for nearly at least over half a year. But if he's really not going to start oral meds, we restart him on CAB-RPV, which we know he has extensive resistance to, and restart the lenacapavir at 42 weeks. Since then, he's continued on this regimen, and he's essentially had functional lenacapavir monotherapy for at least 77 weeks now, and his viral load has remained suppressed. So I present this case not because I am advocating for or suggesting that anybody engage with lenacapavir monotherapy. That's not the outcome that we recommend, but really just to discuss like what are the clinical implications of this case. What it really suggests is potentially that len might have a higher barrier to resistance than we previously understood. And one thing to think about is Capella, the Capella trial, which is what FDA approval for lenacapavir was based on, enrolled only 72 patients or participants. So while this is basically a case report and we don't want to base any decision-making off of just one person's case, the whole trial that we are basing our decision-making on is also quite small. In Capella, there's 14 cases of confirmed virologic failure that also had len resistance. And all of those cases of viral failure were associated with periods of functional lenacapavir monotherapy, either due to non-adherence or to resistance to all of the oral background regimen components. However, if you read that paper, the adherence to the OBR oral background regimen components was only measured via dried blood spots in participants who had viral failure. So a participant like ours, who never developed viral failure, has been virally suppressed the entire time, would have actually never gotten the dried blood spot to even see if they had been adherent to their oral background regimen. I think they did, at least by report, they did self-report, but that data is not presented anywhere that I know of. Self-report of the OBR component adherence. So I think that's just something to think about. Ultimately, I think what this really underscores is the need for further study of the pharmacodynamics of lenacapavir in real-world settings. And then potentially, this case has kind of enlivened our discussions at Street Medicine of like, well, should we be starting lenacapavir in some of our patients that we think might be difficult to find at some point, even if they're pretty adherent to these regimens early on. They have a history of psychosis, if they have a history of severe methamphetamine use disorder. I think this is still very much in the question stage. We don't want to base anything off of a single case or a couple of cases that we've now pulled together with Ward 86 folks, but think something to continue to think about. So I just presented two cases that were kind of some of our more complex cases. And I think if you took that away from this presentation, you'd probably think that we're kind of like Wild West cowboys at street medicine and do things totally off label all the time. That's not entirely true. So far, in terms of retention on long-acting ART, we've had a total of 28 patients who've been on long-acting ART in our program, a mean follow-up of 20.9 months, standard deviation of 12 months, and a range of between 1 to 45 months. All 28 patients, so 100% remain on long-acting ART currently, and all are virally suppressed to less than 200 copies. 5 have been stabilized and transitioned to primary care homes that are HIV-specific primary care homes. 2 have had confirmed virologic failure with resistance due to delayed injections, and those are the 2 cases that I presented today. Of the nearly 500 doses of long-acting ART that we've administered, 93% have been on time, 7% have been delayed by over 7 days, and 3% have been delayed by over 14 days. So the cases that you're seeing today, again, are more anomalies than they are kind of our typical. In terms of where we're administering these injections, 81% are administered at MXM. This is largely because the refrigeration requirements of the rilpivirine component, we want to make sure that we're able to maintain that. But we do have situations where we do outreach to administer injections. So 13% have been administered in tent shelters or permanent supportive housing sites, 4% at syringe access sites, and less than 2% in jail or inpatient settings. So take home points, how much time do I have? Oh, we have a lot of time, okay. One thing that we're continuing to evolve, but has really been kind of a key cornerstone of our program throughout is making sure that we select appropriate patients for long-acting ART. This includes requiring at least 3 months of active engagement with our team prior to initiating long-acting ART. At minimum, we require at least one form of contact to facilitate outreach, either an active and functional phone number. We know that these can often not be active after days or weeks. So that's one thing. Or if they have permanent housing or a consistent location that we can locate them in the community, and that often just requires rapport and knowing the patients for longer than 3 months. Also, when those are not available, making sure that people at least have 2 community contacts or affiliates that we can go to get support with locating them when we need to. A second take-home point is wanting to really focus on our priority population. So we're a status neutral clinic. We're not an HIV specific clinic. And so we want to make sure that we're putting our resources kind of focusing on the patients that really can't access care at an HIV clinic where their services would be more extensive and probably better suited for them. So we really only consider long-acting ART for people who are unable to engage at an HIV specialty clinic. Those with a CD4 count less than 200 or an age-defining illness are kind of our priority, and focusing on people with severe mental illness and homelessness who, because of those issues, are unable to engage effectively in other clinic settings. Finally, this issue of lenacapavir and whether it can be potentially a good medication to use in combination with other long-acting ART agents for our patient population. Still a lot more work to do here. Again, I want to reiterate, just ART monotherapy, including with len, is never a viable treatment plan. So that's not what I'm advocating for here. This case of sustained viral suppression with unintentional len monotherapy, which is due to either delays in CAB-RPV or delayed CAB, really underscore a need for more data on lenacapavir. But I do think that it could suggest a potential role of lenacapavir in combination with other LA-ART agents for highly vulnerable populations like ours, in whom care interruptions are largely unpredictable. All right. Thank you so much for being here. I also just want to acknowledge that Stephen and I are able to do this work because we have a really incredible ETE team now. When we started long-acting ART a few years ago, we didn't have any of this, and I think the reason that we've been successful with the program is because this team has done incredible outreach and really incredible like rapport building with our patients that they want to continue the medication. So thank you so much to all the people on this slide. Thank you to Ward 86 for sharing your clinical protocols. We largely use the same protocols, kind of adapt them to our patient population, but it's a lot of sharing the science with them. So thank you. And yes. Yeah, happy to take any questions. Stephen, you want to join?
That was phenomenal. That's phenomenal. Well, we have a couple from online, but let's take questions from the
Yes. Thank you. That was fantastic. Such incredible work you're doing and such difficult cases, but I learned so much. Audience, yeah.
Well, first, thank you for giving us time to have questions and comments, because I think hopefully everybody's going to chip into this discussion. And thank you both and your teams for the work that you're doing. It is just really, really inspirational. So I'll just pick two things. One it's a comment suggestion, and then the other one is more of a question reflection. So the first one is, when we present like demographics, and then when we do the cases, somehow like what's always in the back of our minds is the person receiving mental health services? Is the person having housing? And I was thinking about the demographic slides. Is like, we know the problem. Could there be like another column? How many people is that problem solved or not solved to? It's a little bit like emphasizing the gap in a real way if the city is really committed to helping us. And like that one case you had in the arrow at the end, you told it what was happening, but all along, like we want to know the mutations, but also the tracking with other perhaps unattended mental illness or things. We have to make the case that the city needs to give us more resources for the other wraparound services. So that's just more of a reflection suggestion. And the other one I was thinking about was this, oh my gosh, this lenacapavir. It's just like absolutely fascinating. And I don't recall if we've had any transmitted lenacapavir resistance. Like, let's just say things are happening, people don't have viral load suppression, and we don't really test for it anyway. So that's just more of also kind of a reflection of the era we're in. And please don't apologize for like pushing this is who we are, San Francisco, you're pushing the envelope. And it's really, really great to see.
Thanks so much. Yeah, I think just in response to the first comment about, I think these questions really, both of the cases kind of invoke this question of like, oh, what do we do about the opioid use disorder? What do we do about the meth use disorder? And as an addiction specialist, I wish that there was like more that we could do for these conditions. I guess for the first patient who had opioid use disorder, I know this is not exactly your question, but I think one thing I've just realized as being an addiction provider in this community is, particularly in the context of homelessness, particularly in the context of severe mental illness, some of our treatments for substance use disorders are still effective, but they've not really been studied in the context of of like this setting, similar to HIV treatments. And so we're finding that they don't always work perfectly. And I don't think that's a surprise to anybody. So certainly I think what street medicine is best at is like low barrier addiction care and low barrier mental health care. But honestly, what I think has been most surprising to me about long-acting ART is, and this does kind of answer your question a little bit better, is there's been a lot of patients that just had no trust with the healthcare system. And so when you talk to them about antipsychotics or talk to them about long-acting buprenorphine, it's not really something that they want to do. But long-acting ART is something that most of our patients do want to do because, and if they have a low CD4 count, or even if they don't, they often notice like physical changes in their body. And so once they start that, they have a lot more trust in the healthcare system. They have a lot more trust in medicines. And so there have been at least 5 patients, there might be more now, but the last time I checked, there was at least 5 patients who started long-acting ART and then have started long-acting antipsychotics or long-acting other medications. And at least for one of them, I know that he's now housed, and I know that none of that would have happened without initially starting the long-acting ART. He's in methadone now. So I think that all these things kind of come together in some ways. And it's weird that, ART is the first thing that's effective for people, but I think because it's a physical change in their bodies, it's something that we can develop rapport with them much more quickly around.
Hey, Nikki, I agree with Diane that this is really great work. And I know in no way are you advocating for lenacapavir monotherapy. Those were the patients not coming back for the cabotegravir. I think we have to take your people with HIV on lenacapavir and our 42, I think now 38 or something people on lenacapavir, and note that we have not had any breakthroughs. We have not had even a need to send to monogram for resistance. And think about lenacapavir, maybe, what is its genetic barrier? Because 76 people in Capella, we have like total between us 46. Like this really needs to add to the database on its genetic barrier, because I don't know what it is. And remember VH199, the new capsid inhibitor from the V company, that only had a capsid inhibitor breakthrough at the lowest dose, which was presented at CROI 2025. So I don't know. I think you're helping to define it. We need to put all our data together and put it out that we have X blips on our CABRIL, but we don't have those blips when lenacapavir is there.
That's great. All right, we'll take one more question from the audience and then we'll go to the chat.
Thank you both for an amazing talk. Really great to go through these cases and hear about your important work. Nikki, I think you highlighted this nicely, but I'd love to hear your thoughts a bit more on when you have this information gap. You get a viral load back, very concerning. You have to wait like a month for the genotype. And you highlighted some nice cases where that came up. Like, what lessons have you learned from sort of being in that difficult information, sparse state? And sort of how has that changed your practice moving forward in terms of rapidity of making decisions with, adding other agents?
So I think that's really interesting, because I think, in that first case of, by the way, that those like viral load blips, or not more so than blips, for that first case of, had it in viral load in the 200s and then 2000s on seemingly like almost near perfect adherence to len plus cab. I still don't really have an explanation of what caused that. And honestly makes me wonder if there's like viral load handling issues of before it got to, I don't actually know. Ultimately, the genotypes didn't run. And so it suggested something fishy was happening. But it's interesting because I think in these two cases, like the kind of ended in opposite directions. When we did get the genotype back for that second case, and there was like extensive CAB and RPV resistance, I felt like shit. I felt really bad. And I felt like I'd made a huge mistake. And it was kind of a big surprise that I don't know if it worked. It did work for quite a long time for him. And I don't know that there's any other treatment regimen that would have worked. But to answer your question, I think ultimately it's continue, like if somebody comes late for their injection and they have viremia, I think particularly with this patient population where you don't know if you're gonna be able to see them tomorrow or the next day, continue treatment until you have evidence that it's not working. And sometimes there's lab errors, and we've all seen that. I can't explain why there was a viral load of over 2000 and we couldn't get a genotype on it. But I think in this setting where we're already doing things so off-label because we don't have other options that are good for our patients, it makes sense to continue care the best we can until it's very clear that something is not working.
There are some great questions online. One is great presentation and work. How do you collect data on how much time it takes the team to find people for administration of LAART injections on average?
That's a good question. I don't know that we've been collecting data on that specifically, mostly because I think we're all just kind of, I think part of what's made this effective, a lot of people have been like, oh, you should do an RCT of this. You should do a clinical trial of long-acting ART. And I think it really wouldn't work in this setting because our patients, what is like the secret ingredient to this working is rapport with patients and the fact that they know our clinical team. And I don't think it would work in a entirely research environment. I think that this is working only because of the embedded system where we have a network of nurses and other providers in the community and at these satellite clinical care sites, at shelters and student access programs where they know us. So back to the actual question, which is, how do we collect data on how long it takes to find people? We're not collecting that data right now. Maybe it is something that we should be collecting data on. I think while we're trying to do this work, it's a balance right now between like, there's so much data that we want to collect, yet we're really trying to focus and position ourselves as clinical care providers more than researchers in this capacity. And so I think it's a balance, but I do think that, we're thinking about getting funding to do research on this specifically, and that's something that we should consider. But right now it's, we meet weekly as a team to discuss how we're going to outreach all of our patients who have upcoming injections for the next week or two. And there's different plans for each patient based on who knows them best, whether we're going to outreach them physically, whether we're going to call them, who's going to be that person who knows them well already.
Yeah, thank you so much for that answer. I think it reflects Diane's question too around how do you define the asks with regards to measuring your time, your team's time. There are a couple of questions, fantastic questions about if you could share a bit more about the psychiatric diagnoses that your patients had in each of the cases and how they were addressed to make headway with ART and potentially timing of that.
Yeah, I think initially what I would have thought before engaging with long-acting ART more over the past few years is that like anybody who we're thinking about for long-acting ART, unless they're like really critically, we need to get them on treatment ASAP because they have a very low CD4 count and they're at risk for mortality. I would have thought we would, we first do our due diligence of helping people get onto treatments for long-acting or any sort of treatments for substance use disorders, any sort of treatments for psychotic illness or mental health conditions. That is not always, as I kind of mentioned earlier, it's not the most salient thing for people because they've been hearing that constantly. They've been told like, oh, why don't you start olanzapine? Why don't you start these medicines that we all know are not ideal. They have a lot of side effects. They cause weight gain. They cause they might help people's mental health in some ways, but kind of be problematic in other ways. So people don't really want those until you can really demonstrate that medicines can be effective and they can gain something that they want to gain from medicines. I think it's really hard to convince people of taking those medicines. And so we've kind of shifted into like, let's start with HIV for some people and have all these conversations simultaneously, but use this as in part to develop rapport. And so, sorry, remind me of the actual question. It was, yeah. 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 Exactly.
Yeah. Sorry. I was just saying that Nikki was echoing the menu approach of offering ART alongside substance use disorder treatment and mental health treatment and sort of it's picking whichever door is open based on the patient. I see a question from Matt.
Okay.
Sorry, I just had a comment on the cost question. So I think certainly important to understand like costs and efforts involved for all of the intensive work that your team is doing. Some of us recently published a cost effectiveness analysis of long-acting treatment for people that are not suppressed at Ward 86. And I mean, big picture message is highly cost effective, but I think a key finding we had is there's about $1,000 of unreimbursed costs borne by the clinic in terms of time, effort. And this is at the Ward 86 patient population, which has some patients with sort of requiring similar levels of effort, but I think often not the same degree of giving injections intense and all of that. I suspect it might be higher for your population. And I think it's just important to highlight that is like an unreimbursed cost and advocacy needed if we're going to build long-acting programs and scale them, that needs to be supported. Yes. So 100 patients, 1,000 patients, obviously.
That was going to be my question, actually,
Yeah.
Nikki. Is there another question in the audience? I don't want to ask one. Okay. So for the 160 patients in your transitional program, you have 28, I think, on long acting. So, who of those meet criteria for long acting, and what's your approach to sort of getting it to those folks who are not already in your program?
Yeah, so sorry, it's 133 that have been in our program over the past year, including the I guess it's really like 25 over the past year that have been long acting ART, because we had graduated some to primary care clinics previously. And in terms of like how we decide whether people are candidates for long acting ART, it's the first thing is there's so many of our patients that are interested in long acting ART. One thing that when we first started this, we didn't know how it was going to go at all. And we knew that it was going to be a lot of work, but we didn't really know what that work was going to look like. And I think it started to become more and more clear after starting our first couple of patients on long acting ART that this is really, it's a lifelong decision for the patient in most of our circumstances. And so we need to be thoughtful about who we initiate, and then like what our clinical capacities are as a team to provide this. And so to Matt's question and your question, I think that's huge. And I think that it's a reason that we should like collect this data on, how much time are we spending locating patients, and how much money are we spending on those resources. I think, again, like the hard thing about doing that is we're set up to be a clinical care operation, and we've been doing street outreach for other indications for a very long time, and we haven't been really collecting data on that super well either. But I think with the new ETE initiative, like Stephen said, ETE is like new money that came into our clinic a few years ago. Not came in, somebody applied for it and all that. But I think it's given us the capacity to start collecting some of this data and to start kind of being more organized about it. Because it used to be a lot of outreach and a lot of like the rapport stuff was there, but the like, how do we replicate this, and how much money does this cost? I think these are still kind of black boxes that we do need to collect better data for to really explain, like, to answer this question of can this be replicated elsewhere. I think it certainly can, but it's hard to say that when you don't have the data that says, how much does this cost? You'd asked a question about, remind me what your question was.
Just like for the folks that may meet criteria, like, is it a proactive approach? Are you outreaching? And because we had, some outreach sort of based on,
that's great.
We think you're eligible. If you come to clinic, we can, this is something we can do.
Exactly. So for patients that are kind of on that borderline, if people have like a low CD4 count and they're viremic, and there's been a couple of cases where we even kind of have been able to link new HIV diagnoses to existing patients just because we know them. And in those cases, we feel like it's important that we help them get suppressed as soon as possible. So there's like kind of a priority population that we kind of do more intensive outreach for, or patients who are pregnant, patients who certain priority populations. And then for people that have a CD4 count above 200 and who maybe have been able to take oral ART at some point in the past, but they're not able to now, for those patients, we have kind of more of a graded system of, okay, we know that you want to start long-acting ART, or we don't have the capacity to like bring this to you every month or do extensive outreach. And of course, we might end up doing that anyways, because life circumstances change for patients all the time. But for those patients, we have a few patients kind of in queue like this right now. We kind of give them some targets of like, come in weekly, come in monthly. And if you can demonstrate that you're able to do that, then we can kind of, and if you could, by the way, try to find a phone or try to hold on to a phone through links, et cetera. All of these things would make it more likely that we can actually continue this long term. And then once we start seeing patients kind of more regularly, if we've seen them monthly for 3 months, that's kind of our eligibility benchmark for like how much engagement that the person needs to have with our team before we start. Then we start long-acting ART. And there might be, initially we had capacity limits. We'd say like we're not going to start more than 5 patients. And we first started this program just because we didn't know what it was going to look like. Now our capacity is probably somewhere around 25 patients, just because I think for long-acting ART in particular, PrEP, we're more open about. So basically anybody who's interested in long-acting PrEP can be on long-acting PrEP, just because our concerns of what happens if they stop is much lower. But yeah, I think we'd still probably want to hold a capacity of around 25, but this has also kind of encouraged our team at Street Medicine to start graduating more patients, which historically has been harder to do. It's always hard to graduate patients when we we're the only providers that they know for 5 years now. And they have a lot of mistrust towards the healthcare system, but it does encourage us to kind of move people along.
Great.
Thank you both so much. Phenomenal discussion. Let's give them a round of applause. We didn't get to all of the questions, so please send emails to Nicky or Stephen or come down and chat right now. Thanks, everybody.
Thank you.